Pleasure to introduce our next speaker, who is Ajith Kumar, who's one of our consultant clinical geneticists at GOSH. I think been in post since 2006. And Ajith has a particular interest in cancer genetics and neuroendocrine tumors, and relationship between cancer genetics and dysmorphology. But Ajith is going to talk to us about the use of HPO in the clinical environment, particularly clinical genetics, and also a bit on perhaps on EPR integration, but we're going to look at that as well a bit later on. So over to you, Ajith.
Thank you, Robert. So I'm going to talk about HPO in terms of my own clinical experience with rare diseases and cancer. So rare disease definition would be a condition that affects fewer than 1 in 2,000 people in general population. But the vast majority of them are genetic disorders or single gene disorders, but not all of them. Just going through some of the terms that we might come across in this talk. So syndromic diagnosis, syn means together and domain for running together. So a cluster of clinical features, signs, and symptoms that go together. Dysmorphology, dys is abnormal, morphology is shape. Genotype versus phenotype. So genotype is the genetic makeup, and phenotype, from the Greek term pheno or appearance. So it could be clinical manifestations, imaging findings, or lab findings as well. So yeah, we've gone through the definitions of ontology. So it's a set of concepts and categories in a subject area that shows their properties and relations between them. Now, thinking of the spectrum of human disease, only a small proportion of human disease is due to single gene causes. At one end of the spectrum, you can see Duchenne muscular dystrophy, hemophilia, phenylketonuria, thalassemia. But the vast majority of human disease either falls into the multifactorial or environmental spectrum. So when we talk about the various diagnostic tools that we are using, we're talking mainly about single gene disorders. So cataloging single gene disorders. So Victor McKusick, in 1966, he started a catalog of single gene disorders called Mendelian Inheritance in Man. Used to be published in huge volumes of books. And in 1987, it became online, Mendelian Inheritance in Man, which is widely used across the world. Now, differential diagnosis of sort of single gene disorders in 1960s and 80s, dysmorphic conditions, we used to rely on books like Syndrome of Head and Neck by Robert Golan, or Recognizable Patterns of Human Malformations by Smith. So, people used to come back from clinic and then thumb through these books, trying to make a diagnosis. So moving on to pioneers, and we used to work here in this hospital. Robin Winter and Michael Baretza developed London Dysmorphology database, which became available in the 1990s. From the first edition was in 1990. So you can see there that they follow an ontology, but it has been improved on considerably since then. So we used to make differential diagnosis, inputting data into the London Dysmorphology database. So in 1996, Robin Winter, who sadly passed away at a very young age, wrote this paper saying, what's in a face? So there's this condition called Williams syndrome. And then if you look at older papers, children with Williams syndrome are described as having elfin facies. So not many people have seen elfins. So what are you talking about? So in my mind, if I came across an elfin, elfin should look like a child with Williams syndrome. And later on, to try to unify the phenotypic categorization, there was an international collaboration, again involving one of the consultant dysmorphologists here, Raoul Henneken, and lots of other people from across the world, trying to define terms used in dysmorphology. So came out as a series of papers in Journal of Medical Genetics as elements of morphology. So describing various, features about the nose, the face, ears, hands, and so that was an improvement and trying to attempt to standardize, descriptions. And in 2008, the first paper on HPO in phenotype ontology came out. So HPO can be seen as the language of genomics. The more complete the phenotype, the better will be the analysis of the data. Completing a request form for whole genome sequencing is a time-consuming, frustrating process sometimes, and you can take up to an hour to do one family, actually. It's not just HPO terms are not just a hoop to jump through to get whole genome sequencing done, because the rarer the phenotype that you can enter into it, the better will be the diagnostic yield. So people have looked at interoperability between phenotypes and research and healthcare, existing diagnostic coding systems like ICD-10 and CT. And interestingly, the mapping was only about 33% in this particular study. So when we acquired the new EPR EPIC at GOSH in 2019, a few years before that, so we were looking at various options, and we realized that EPIC did not have a good way of capturing rare disease diagnosis, particularly new single gene diagnosis. So a decision was taken to acquire the paid for software called Phenotypes as well, which can draw complex pedigrees. It can enable cancer risk calculations. And it can also provide rare disease diagnostic insights. So it can pull in differential diagnosis from women and help with the diagnosis. So deep phenotyping is a term used to describe careful documentation of phenotypic data. And as has been alluded to before, rare but distinctive phenotypes have greater diagnostic weightage. So if you think about intellectual disability, you can have thousands of differential diagnoses. So if you had congenital heart disease to that, it narrows to a few hundred. So if I then say, the child also has hypocalcemia, cleft palate, then you start thinking of differential diagnosis, including the George syndrome. So one practical aspect of this is that we could be ordering whole genome sequencing too soon in some instances, without waiting for completing the other investigations. Say, for example, a child with microcephaly. So if you order whole genome sequencing before the MRI result is back, you could be missing out on important phenotypic data. And also, it is very difficult to go back, because of the source constraints, to go back and ask the lab to reanalyze the data and add HPO terms. It all takes a long time. So previously, we used to go from a phenotype to a targeted gene testing or a panel test. So here you have a patient who has these, papillary lesions around the nose, and periungual fibromas and dental pitting, angiomyolipoma. So the phenotype fits a condition called tuberous sclerosis, and we know that it's due to mutations in either one of two genes, TSC1 or TSC2. So here you started from the phenotype, and then you order the test. So what if the phenotype is not distinctive? So a large proportion of patients with developmental delay or intellectual disability, they may not have distinctive features. So we now have a gene agnostic approach. So microarray, for example, again, we don't necessarily need to know what we're looking for, and we can request a microarray which looks for deletions and duplications across the genome. Whole exome sequencing and whole genome sequencing are also gene agnostic. Now, when we do microarray, we have been coming across a number of loci in the genome where deletion or duplication could predispose someone to developmental delay, intellectual disability, behavioral issues such as autism spectrum disorder. these tend to be recurrent deletions and duplications. However, interestingly, some of these patients or members of the family may not show a phenotype at all, in spite of having the same deletion or duplication. So those are some of the examples of the recurrent deletions and duplications of neurosusceptibility loci. So the explanation for this is the familial background influences clinical variability in these conditions. So if you look at this family, family A, family B, so their potential might be here, and having the deletion and duplication might push them back, but still, it might fall within the normal range. Whereas if it was here to start with, having the deletion and duplication, you push them back to where it's considered unuseful. So whole exome and whole genome sequencing. Whole exome sequencing, looks at the protein coding parts of the genome or exome. Whole genome sequencing covers intronic regions as well. But currently, the genomic medicine services for whole genome sequencing use a targeted panel-based approach, and they don't go too deep into the introns either. So it's important to arrive at a diagnosis as early as possible, particularly in the context of treatable diseases. And in view of that, the generation study or targeting treatable, the newborn genome screening program has been launched. Now, in the past, for most genetic conditions, there was no treatment. And so, whereas nowadays, there are conditions where interventions such as changing the diet could make a dramatic effect. Gene therapy for various conditions, all of this, makes it imperative that we pick these up early. Now, going to an example of a referral I got. So this was a referral from an orthopedic surgeon saying, this child has multiple congenital problems, extreme flat feet with pronounced Achilles contractures and skewed foot. So when I saw the child in clinic, the father had come with a 72-page report with two genes identified as either one was considered likely pathogenic, the other was a VUS, but the clinical features did not fit, and they started with a query neuron syndrome diagnosis. So when I saw the child, he looked very much like this child here. And a long time ago, I had, as a training in clinical genetics, I had seen a child like that. And almost 20 years down the line, I saw this child. And, as a registrar at that time, the gene for this condition had not been discovered. And the gestalt diagnosis of this child, it's gestalt by the definition is an organized whole that is seen as more than the sum of its parts. So I immediately thought of the condition. And also using phenotypes, I just entered the HPO data into phenotypes. So, the first diagnosis that came up in the differential diagnosis matched what I thought about the patient, Schnitzler-Goldberg craniosynostosis syndrome. So I asked the lab, this was a lab from abroad who were not actually accredited to provide diagnostic testing. So I asked them to go back and look at the data again. And sure enough, the child had this missense mutation in ski gene, and which clinched the diagnosis. So even if I didn't make a gestalt diagnosis, if I had put in the HPO terms into phenotypes, it would have come up with a differential diagnosis. So, as trainee clinical geneticists, we are trained to pick up a diagnosis which you may or may not make once or twice in your entire lifetime. But if you break it down into HPO terms and use the differential diagnosis feature, you can come to a diagnosis even without that experience. So ascertainment bias. So if you know that condition A is caused by mutations in gene B, but the phenotype is not typical of condition A, and a variant is identified in gene B. Should we ground it as because the phenotype does not fit, or could it be a different phenotype caused by mutations in the same gene, and could it be a widening of the phenotypic spectrum? And we are finding it increasingly with gene agnostic testing. Just a few examples of different phenotypes caused by mutations in the same gene. So Marfan syndrome is typically associated with tall stature, long digits, scoliosis, and it's due to mutations in FIPL1 gene. But interestingly, mutations in a particular part, exon 41 and 42 in the TB5 domain of the gene can cause another condition called acrometric dysplasia, where they are short, they have short fingers, and their joints are stiff, unlike Marfan syndrome patients that they have lax joints. Some of the other examples would be mutations in different parts of TREB-BP or EP300 genes can cause different conditions, completely different conditions. Likewise, gain-of-function mutations in RET cause a condition called MEN2B, multiple endocrine neoplasia type 2B, associated with medullary thyroid cancer, hyperparathyroidism, and they can also develop pheochromocytomas. Whereas loss of function mutations in RET can be associated with an increased risk of Hirschsprung disease or congenital aganglionosis, which is present with constipation in newborn babies. So the type of the genetic change and the location of the genetic change is also important. So this is a child I had followed up for a number of years, and I saw him when he was about 7 years old. And the story was that he was shot, and his father was shot as well, and the parents had separated, so I never saw the father in clinic at all. And he continued to be shot. And I think at some point, the endocrinologist started him on somewhere here, I think. Started on growth hormone, which made a slight difference, but he continued to be small. So the initial clinical suspicion was hypochondroplasia. So because he had short limbs, mainly this part of the limb and the thigh bones. So we then did some X-rays to look for other features of hypochondroplasia, which he did not have. So one of the other features of hypochondroplasia is the interpedicular distance of the lumbar spine would be narrow. So the distance between the pedicles is really looking like this. So he didn't have that. So, and there were no other skeletal features of hypochondroplasia. And then we did a genetic test, which was available at that time. It was looking for specific mutations in the FGFR3 gene. And the result came back saying hypochondroplasia is not confirmed. So years go by, and this paper gets published. So novel mutations in cysteine residues in the extracellular domain of the receptor cause achondroplasia or achondroplasia. So we went back and looked at that particular variant, and it was here. So the green arrow shows there this patient's mutation was, and clustering of other mutations causing hypochondroplasia. And then there were other publications. Again, we reviewed the skeletal findings. Apart from mild metaphyseal splaining the long bones, short limbs, there was no obvious radiological features of hypochondroplasia. So this is an example of widening of the phenotypic spectrum. And in the meantime, the lab had found the same mutation in another patient with short stature as well. So which made us conclude, so that patient's report, initial report, no clearly pathogenic variants. The particular variant was reported as a BUS initially, and then we issued an amended report saying this is likely pathogenic. So yeah, variants of uncertain clinical significance. So we come across a few of these, in our practice, and then apply the ACNG guidelines, which looks into how frequent is this variant in the normal population databases like NOMAD, in disease databases. What does the computer modeling say? All of this is and other factors also taken into consideration before deciding, the classification of the variant. And also, once we, because we have a gene agnostic approach, so we may find a variant and then go back and look at the child or the patient again, with the variant in mind, and this is called reverse phenotyping. So initially we used to go from phenotype to genotype, and now we're going back to phenotype after receiving the genotype information to see if there are specific changes, if specific phenotypic features associated with the genetic change. So, genetic information historically has existed in silos. So within hospitals, paper records, even electronic records, we just have information within the hospital. So I may be puzzled by a particular case, whereas somebody else might have reached a conclusion about the variant of uncertain significance based on extra information they have. But that exists in a silo and it's not shared. And therefore, we don't have that information. So it's important to be able to share this information widely. So even though we have phenotypes at GOSH, it's only some specialties, including clinical geneticists and inherited cardiovascular services and a few other specialties that use it. So information on phenotypes is also within the hospital, kind of in a silo. So more recently, the work from the EPR team, we have incorporated HPO terms into to EPIC or EPR, and Moise will be talking about it in greater detail in the afternoon. So what we are trying to achieve is earlier diagnosis, fewer variants of uncertain significance. So a practical way of finding HPO terms, you can go into the HPO website, you can put in your term and it'll come up with the corresponding HPO term. And also there are other software that's available where you can put in a whole bunch of text and it'll come up with the HPO term. So Dr. HPO is one of those. So these are some of the various web-based resources that we use, day to day, and many of these have been alluded to earlier. So Decipher, Nomad, 100,000 Genomes Project, ClinVar, Gene Matcher, and the last one is Franklin, which is a web-based tool where you can put in, various variants, and then it helps to classify those variants. Thank you.
Thanks, Ajith. It's really good to see these things being used in clinical context, and also some of the challenges as well, and all the pitfalls. I don't know if anyone's got any questions for Ajith in the room, or if, I know there was a question online earlier, but which we may come back to later, if because it was more relating to Exomizer. Oh, Paul.
It's more of a comment. So Ajith, thank you so much for that. And I just wanted to say that your presentation really shows how the clinician and the clinical is so crucial to diagnosis of rare disease, and the fact that you managed to blandly blasé all the way through saying that you connected two patients 20 years apart, I think is totally impressive and speaks to you and your colleagues' amazing skills in this field.
You will echo that, rely on their skills a lot. I mean, I think that's, I've got a question. I mean, this whole question of capturing the gestalt, which, a patient walks into the room and you look at them and you kind of get a sense of an idea of what the diagnosis might be. And also you try and define that by breaking down the phenotypic features and the HPO terms, and sometimes that works, but sometimes it's quite hard. And it seems to us, looking at the clinical justice and the way that you sometimes assess patients, you're able to capture a gestalt, which sometimes is quite hard to define in terms of specific HPO terms. So is there a risk that if we rely too much on the kind of deep phenotyping approach of breaking it down into the HPO terms or whatever terms, and then using that as our kind of primary criteria, is there a risk we might lose that kind of ability to capture that gestalt, even if we can't always define it? And we know that, I think you're a very good example, but there are many clinicians who seem to have the ability to put things together and sometimes can't even define, I think, how they do it, what it is, but they come up with diagnosis.
Yeah, I have to say that in a good year, I may make 1 or 2 desktop diagnoses. Yeah, but I suppose if you have seen one before, kind of sticks in your mind, and then, especially a rare combination of features that sticks in your mind. And when you see a second patient, it usually comes to you. It is an important skill to retain, but with computerization and basically breaking things down, even you can do it even without that skill. But yeah, and also increasingly these tests are being ordered by non-geneticists.
I suppose if we do completely break it down and try and use an HPO approach, and will we capture everything that the human phenotype can do, or the experienced clinician can do? Because the less you do it, the less skilled you become, right? So, so anyway, maybe it's a slightly philosophical question. Okay. Yes.
Yeah, just a quick comment on entering the HPO terms. Like my experience of analysing cases using XMISE or the 100,000 genomes project, you don't need to be perfect quite often as well, because you combine the sequence data, there's only so many de novo variants, etc. So don't overstress it. But it's also really important to add the obvious HPO terms, like the common ones, such as intellectual disabilities. I found quite often in the 100,000 genomes project, the clinicians, it was so obvious they didn't enter it. So you could get retinitis pigmentosa cases about that HPO term. And then, of course, automated tools like XMISE completely missed the diagnosis.
I think that happens, I suppose, each of us, the specialists, you tend to concentrate on your area and then leave out stuff. So if I now see a patient who has been seen by a neurologist or one of the other specialists in the hospital, I usually contact them and say, I'm requesting whole genome sequencing and requesting this panel. Would you like to add something? Because if I miss a chance and the result comes back, if I have to go back later, that's a much more time-consuming process.
Yeah, I think that's what the drawbacks. Seeing the approach that there was kind of one chance to capture the HPO terms, and then you were disconnected with the clinician.
Yeah.
So.
Thank you, Ajith. That was great. Just coming back, that was a really important comment you made about requesting WGS too soon. That is the direction of travel. That's what we want to do, and it's amazing. But particularly in the context of mainstreaming, if clinicians don't have the ability to come back into an epilepsy or the genomics MDT, clearly epilepsy is on my mind, working in that area, but the genomics MDT have that ability to go back and add in the additional information, we will lose diagnoses. So I think that is a question for all of us who are involved in developing clinical pathways and making sure there is scientist time and there is clinical genetics time, and that we're bringing the specialists, clinicians and referrers in for those discussions. Thank you, that's important.
Thanks, Sophie. There's a couple of questions online. One is, how can we utilize the data from HPO phenotypes and epic data and improve the patient life and research outcomes? Well, I guess that's kind of the reason we're all here, right? And it's a big question. I don't know, actually, if you want to comment.
I think the ultimate aim is to make a diagnosis earlier, especially crucially important for conditions for which there is some kind of intervention. And one of the things that have kind of stuck in my mind over the last few years is, two siblings with SMA, the older child is in wheelchair, not having had the treatment, and the younger sibling is running around. So, making the diagnosis earlier, having fewer variants of uncertain significance, as time goes by. So, yeah.
Thanks. Then there's a question. Since WGS is still truly not fully WGS, because it's not picking up everything, will not diseases be missed? People may be under a false impression that the appropriate test has been done, but it's still a panel. When will it be a proper WGS? I guess it's talking about agnostic testing as against to panel testing, which we talked about as well.
Yeah, I don't have a time frame in my mind, and I think there is this conflict between trying to get all the low hanging fruit, and then it may happen in due course of time. I don't have a time frame in my mind. As the techniques improve and the information improves as well.
But I guess it's no such thing as completely comprehensive WGS, right? Because it's all in the, you can pick up variants or what is a variant, how to interpret the variant. So the idea you will ever have a fully complete WGS process is kind of unrealistic, right? It's always going to be on interpretation as well as the data.
Do you want to?
Yeah, I think they're probably talking about the genomic medicine service, but there they're kind of using a panel and XMISers, so people do get the XMIS results, and that is looking at the whole WGS. It's filtering down because it's not a panel approach, you're looking at every possible gene. So I'd argue it is WGS.
Yeah.
Question. When we have data, for example, that is managed by pharmaceuticals, and we can't upload this data in a generic database, but we want to report this data, would it help adding on the background of our research the frequency of certain HPO terms in this population? Can this number, or can, if we define our population using HPO terms or similar terms, can this help towards a better understanding of the genetic disease? Like having the background data of my population has a certain disease, male, female, age, treatment, and then HPO terms in different frequencies in this population. Does this help best describe our population? And can this data be used by people who are working with HPO terms?
I think Jules might be better placed to answer that question.
I'd say yes, but maybe it's I can say in the end yes, and that's the kind of thing that I think it would be very helpful for, because you can actually define all this data with collaborative packets that you can then start to extract frequencies in which get a feature. In terms of algorithms that we have automating sort of phenotypic matching based on frequency, we haven't fully implemented these things. We're testing them, but that's really where we're going to go.
Thank you very much. One more question.
So certain aspects of clinical phenotype may be relatively subjective. So for example, in immunology, susceptibility to infection. Sometimes it's obvious or recurrent infection, for example. Sometimes it's less obvious. In terms of trying to target your genetics and get a specific and a precise approach to diagnosis, in your experience, is it better to be more inclusive when there is some clinical doubt over a subjective phenotype? Or does that risk then restricting your search? So the patient, if I think a patient may have recurrent infections, but does it actually have susceptibility, diagnosable, definable, measurable susceptibility to infection? Me including that, does that narrow down the search in a way that may cost the patient a diagnosis?
Not necessarily. Again, what do you think, Jules?
It's like fuzzy matching. It's not one exact. I mean, I think some cases it will help, some cases it won't. It's probably not a yes no.
Yeah, and sometimes in certain conditions, you do get kind of undefined sort of immunodeficiency. In fact, when it comes to immunodeficiencies, the HPO terms are not very precisely defined, and in case involved in improving the HPO terms. So